Good evening, Mahendra.
Sir, good evening.
Nice to see you after a long time.
Yes, sir. Right.
So today, mainly you, Ganesh, and then Nalini Madam.
Yeah, basically, main Nalini Madam actually.
Yeah, she will be. Yeah. So initially, we will start with the case, and then she will join.
Okay.
And then she will talk from her perspective about the investigations and pre-op management in detail.
So, sir, she is not presenting as a first, sir. That means everybody will get an idea how to approach.
How?
Before starting the case.
After history, I'm calling her.
Acha, okay.
So I'm calling her. She is supposed to join. I'll just tell her. I'll message her. Say join as soon as possible, so that you can guide the.
Right. So today, who is presenting?
Today, Achint is presenting, but I think two people are answering.
Yeah.
One is Ojas. Ojas, you are answering?
Yes, sir. Yes, sir. I am answering. Yes.
And who else is answering? I'll just see.
Hiren bhai, good evening. Gite sir, good evening.
Good evening. Good evening.
Good evening. Good evening, sir.
Sir, good evening, sir.
Good evening, Gite sir.
आज क्या मैडम का ही क्लास है शायद ना, मैडम लेक्चर लेने वाले हैं ना?
Yes, क्या बोले सर?
आज मैडम ही लेक्चर लेने वाले हैं शायद ना?
हाँ, तो मैडम को मैं बोलता हूँ ना.
नहीं, आज दूसरा केस प्रेजेंटेशन तो नहीं है ना? We are directly on the madam's lecture.
नहीं, there is a case presentation. So initially we'll have some case presentation and then she will join. So I'm just requesting her to join as soon as possible.
क्या केस है?
वही Pheochromocytoma जो they will.
तो same topic and later on talk by madam.
Yes.
Okay.
Whoever is presenting, just one suggestion, please don't present this case as a pheochromocytoma,
Yes, sir.
Yeah.
right?
Okay, sir.
Yeah, it should be something like that, adrenal mass, right? Okay.
Yes, sir.
Yeah, and how to approach the adrenal mass, adrenal lesion.
So today Ojas and Mriganka are going to answer.
Okay, sir.
Yes, sir.
Fine. So shall we start then?
Yes,
I
sir.
think Dr. Bakshi is he join or
1 second, just find out. Can
I'll
you just,
find.
otherwise can you just call him?
Yes, sir. I'm calling, sir.
Hello, Dr. Ojef.
Yes, sir.
Can you please switch off your fan?
Oh, yeah, sure. Sorry, sir. Yeah, okay. Is it okay? Yeah.
Okay.
Yeah, sorry. Yeah.
So Dr. Ganesh Bakshi has joined. Hi, so we are starting. So if you join earlier, you can guide the student. Okay? Okay. See, madam is joining in 5 minutes. Okay, so we just wait for 4-5 minutes and then start. Is it okay?
Okay, sir.
Because then she will guide us.
Gaurang sir से बात हुआ. He is joining in 2 minutes. Gaurang Shah, sir. Hello.
Hello.
Faculty in workshops in various centers. So that way, I would like to thank him. And of course, my wife also had a special relation with his wife because they used to meet in the conferences, and she fondly remembers how during the recent question conference.
Can anybody tell where is the sound coming from?
I think Pankaj is.
Okay, sir has unmuted itself.
Pankaj sir, good evening.
Good evening, everyone. Sorry, I'm on another. I'm on the condolence meeting, so I'll just keep myself muted for some time.
Okay.
Yeah.
Rakesh, can you make Nalini madam host and unmute her?
Good evening, madam, and welcome back again.
Good evening. Good evening.
Thank you very much, Nalini.
Of course, yeah, sure.
Yeah. So
Madam,
shall we
good
start?
evening, Mahendra here.
Yeah, that will be wonderful.
Yeah. So we will just start with the case and then you guide it, all the students.
Yeah, yes, please. I would love that.
Okay. Achin, please start.
Yes, sir. A Hindu gentleman, 30 years of age, resident of Mumbai, clerk by profession, complains of headache since 3 months.
So this is a history, Nalini.
Yes.
The way we start is we just give the initial history and there are two students who are answering.
Okay.
And we just ask them that what are the questions you like to ask them, guide them. So in a short history, after that we go for examination and investigations and management.
Sure, I'll get that.
Okay. So two people are answering today, Mriganka and Ojas.
Yes, sir.
Okay. So Ojas, this is a history.
Sir, yes, sir. So regarding headache, I would like to ask what is the onset, duration, and the progress? What is the localization of the headache? Whether it was just the frontal area, parietal region, whether there were any triggering factors for the headache, like any visual, audio, or any other stimuli. Whether the patient has hypertension or there is a history of hypertension, whether it is taking any hypertensive medications in the past. Whether the patient is using spectacles and has got his visual acuity checked. Also, yeah, this was the main. I would like to ask for the headaches. Sir.
Nalini, you can just guide them.
Oh, yeah, sure. So, you know what? I think I have a strong bias here in the history itself. And I mean, if a urologist is handling a patient who's presenting with headache, there is a lot more which is happening, right? I mean, I think with the headache, associated symptom complex will be of huge importance to you. For example, if these headaches are sort of associated with sweating and palpitations, or if they're kind of getting triggered on anything that is giving increase in abdominal pressure, like some of our patients talk about when they're sweeping the floor, bending over and sweeping the floor or brooming the floor, they get into headache. Suddenness of the whole story, paroxysmalness of the story, that will be of great importance to you. What you suggested was kind of a approach to headache in general, and I think you will want to be a little more organized in terms of a patient who's coming to you as a urologist. So I would kind of look at it that way.
I think that is the right way of taking the history instead of taking a journal. Fine.
Okay.
Achin, go ahead.
Yes, sir. The patient was apparently asymptomatic 3 months back when he started developing headache all over the head, throbbing in nature, insidious in onset, gradually progressive. Initially, it was intermittent, now it's continuous type, aggravated during exercise, walking, relieved temporarily with medication, associated with nausea. On further history taking, a patient also said that it is associated with episodic sweating, palpitation, easy fatigability, and hot flushes occasionally.
Yeah, go ahead.
No history of vomiting, visual disturbances, no history of trauma, no history of fever, burning maturation, lithuria, hematuria, no history of any previous similar complaints, no history of facial puffness, lower limb edema, exertional dyspnea, no history of any lower urinary tract symptoms, no history of any decreased urine output.
Yeah, Mriganka, you want to ask anything more?
So, whether it is associated with any kind of food, specifically wine or chocolate, whether any other precipitating factors like tight cloths does micturition predisposes this kind of headache, and that's also.
So, Meganka,
Yes, sir.
why did you ask about wine and chocolate and micturition? This is a very, very vague history of this thing, sweating, palpitations. And again, I want to know a hot flush, how patient will describe the hot flushes. Did you ask any leading question, or what type of hot flushes uh, you took hint from the patient?
Sir, hot flashes will be episodic, or it can be also sustained. And
so, did you ask about the patient of hot flashes, or patient told about you about the hot flash, because patient having only headache?
No, sir.
Right.
When we asked the leading questions, then only patient told, yes, I have this.
So headache with hot flashes, what is the correlation with that?
so these are episodic flashes that occur in patients with.
With what? With what? Yes, I want to know that word. With what?
Is a sweating and palpitation and flaring.
I think this happened because you knew the diagnosis. That's why you asked these questions. Right? Because otherwise, by the easy fatigability, the hot flashes, and asking about this coffee and chocolate, I also want to know the correlation between your history and these two specific food items in the history.
So this food triggers generally this kind of
Only these two food triggers means the
no, sir,
hypertension.
even seafood and plenty of others.
Okay, something very uncommon. Okay, madam, anything you want to say at this stage?
Basically, I think I just want to help Mriganka. Is that right?
Yes,
Mriganka, I think I think you're kind of pre-primed to think along the lines of Pheo, and then you're going to ask something like, what kind of food items work as a MAO inhibitors and hence worsen the episodes of, the Pheo related symptom complex. It's kind of pretty uncommon for most of the Pheos to account for this kind of history and kind of related to food items. It's not a very common thing to happen. So let's not get into very uncommon situations when the examiner sort of just wants to go all out at you and hold you by the neck. Don't try to do that, okay?
No.
It may be more important for you to say that a 30-year-old who's possibly presenting to you with maybe pheochromocytoma, if you already know that kind of a story, go to the family history. That's much more rewarding for you to elicit all different aspects of syndromic components of Pheo in the family members. The younger the individual, the more likely is that the family history is positive. And sometimes you just don't connect it, you see. Like this week, I saw a very young lady, again, a 30 years old, who has come with a history of pain in the back. Okay, it's a pain in the back in a manner that she cannot lie down flat on her back. And then she starts going through multiple sort of consults and investigations and so on and so on. Unfortunately, nobody takes the history that about 2 years ago, she's got a sudden blindness in one of her eye. Her mother had a similar history, and that's a typical story of a VHL syndrome. Okay,
yes.
it's a typical VHL syndrome where she has a syrinx sitting in her spine, which is giving her the root pains when she lie down flat on her back, and that bleeding in the eye was the retinal angiomas, which is not connected by people. You see, so the thing look disconnected till you understand and connect the syndromic components. Okay. So that could be very, very rewarding. So always remember to ask for any significant medical history, and then suddenly patient will pop out to say that, yes, this happened to me or my relative or whatever. So that's very important history to get into. Okay?
Yes.
Sure.
Yes, ma'am.
Yeah. Swachin, go ahead.
Yes. Past history, patient is a recently diagnosed case of hypertension since 7 days and on tablet prazosin 10 milligram twice a day. No history of any diabetes, mellitus, ischemic heart disease, no history of any previous surgery. Family history, predominantly nothing contributory. No known syndromic conditions in family. Personal history, diet is mixed, appetite is adequate, bowel bladder is regular, sleep is undisturbed, and patient is a non-smoker, non-tobacco chewer, non-alcoholic.
So just which are the syndrome you will connect with this disease if you want to?
So based on the current history and the past history and family history, these complaints could be related to either one is cardiac issues because the patient has hypertension and palpitations. Second could be anxiety, neurosis, and third would be related to any pheochromocyte adrenal lesions like pheochromocytoma or maybe a paraganglioma.
So simple question to both the students. Why patient of headache will come to you, first of all? So if this patient complaining of headache, he should come to urologist.
So probably he has undergone some investigation.
99% patients who complains only headache, why he will come to urologist? He will not. He will go to the physician. Okay. Until and otherwise some urological symptoms, he will not come to urologist.
Yes.
Yes, sir.
So this is the first, the crux of the story is if he is presented to you, suppose with headache, what are the causes of headache? Urological causes of headache.
So,
It may be in any condition related to increase. Okay, any condition which increases or
Blood
decreases
pressure.
the hemodynamics of the body, like
Yes,
renal artery
renal
stenosis,
hypertension.
like
Hypertension.
the problem in the aldosterone mechanism, problem in the epinephrine mechanism. Why it is the symptomatic response due to epinephrine.
yes.
So if you know what is the presentation due to epinephrine, what is the presentation due to dopamine, then you can able to judge it. So as madam says, associated paroxysms, associated symptoms due to epinephrine, suppose headache, profuse sweating, palpitation, apprehension, pallor and flushing. So these all symptoms are due to epinephrine.
Yes.
Okay. So first question, if I am examiner, I will say why you are treating the patient of headache? Why he will come to you? And if he really come to you, then you have to think everything. Condition related to the kidney, condition related to the adrenal. These are the only two organs which causes changes in hemodynamics of the body, which will end up into the headache. Or systemic present of the organs. Okay, go ahead.
Okay.
The question asked was which syndromes are associated?
Sir, VHL syndrome, NF neurofibromatosis, MEN 2A, 2B, and
MEN 2A.
Sir, von Hippel-Lindau syndrome, neurofibromatosis type 2, MEN syndrome, succinate dehydrogenase type B and type D. Yes, sir, these are the syndromes associated with.
When you're telling these syndromes, you should tell what is the possibility of pheochromocytoma.
No, Dr. Hiren, just one query. Abhi, we are just on history. And just based on history and having only hypertension and few symptoms, how we can this thing say about the syndromic thing until we don't know the site of origin at present.
So because the question was asked, I'm saying they should know the association of syndromes with Pheo. What is the percentage?
That means we know it is Pheo in the history. I want to point out, let history and let her have some investigation, let have a site of origin, or maybe some examination, something. Then we can discuss about the syndromic picture.
At this at this stage of examination or case presentation, there is no any clue which suggests that this patient had a Pheo.
Yeah, right, sir. Correct.
Having headache doesn't mean he had a Pheo. Having hypertension doesn't mean he had a Pheo. It may be renal related hypertension.
Right, sir. So if there is any past history of one of the components of the syndrome or family history, then we can still complete that history, whatever in the history, like for familial diseases with Pheo.
So Nalini, you have been examiner. Now, if in the exam, how the student should go ahead with the history?
You know, his history has been kind of quite complete. And I think we are now talking about the interpretation of this history. So really the patient, though he has presented with headache, the first question that even Dr. Gite kept on asking was, why will a headache presentation land up with a neurosurgeon? I mean, it just doesn't have a connectivity there, right? So I think something to enhance and save your skin as a student, you ought to be coming up to say that as a part of this assessment, somebody has decided or assessed to find an adrenal lesion for which the patient has been referred to you for further assessment. Somewhere you might want to just bring that in so that you are above this questions and you proceed more towards the urology part of the spectrum, right? I would do that. I would certainly bring that up somewhere now to say that headache with or without is associated symptom component for which he was evaluated by a physician who has found adrenal lesion for which the patient has been referred to us.
I think this is a very good way of presenting. Yeah. Okay, Ojas. So now next one.
So first, I would like to do basic investigations for this patient, which will include a CBC, a serum creat, and a sonography or a renal arterial Doppler, as well as I will also like to do have the blood pressure charting of the patient and
before that, you don't want to examine the patient?
First examine the patient, sir. Check his resting heart rate, resting pulse rate, heart rate, blood pressure in supine and supine position. Also like to have a record of the blood pressure. Then examine the abdomen for any palpable any mass or lesion, and and in the general examination, look for any signs of and do a general examination, per systemic examination, in which per abdomen examination look for any lump. Then proceed ahead with investigations.
Okay.
Ojas, again,
Yes,
I'd like to request you. You're a urologist, right?
Yes, ma'am.
When a person has presented to you with headache as a dominating symptom complex and coming to you as a neurosurgeon, it is already pre-decided that there is an adrenal lesion for which the patient is being sent to you for assessment. At that point of sort of deduction process, don't harp on palpating the adrenal mass so vigorously. You actually don't want to dig into Pheo per abdomen on your palpation so vigorously, you can just precipitate one of the crises, which you don't want to really do. Yeah.
Oh, yes, ma'am. Yes, ma'am.
Be kind of little less emphatic on that part of the story. Yeah.
Yes, ma'am.
I think this is a very important, valid point she has told.
Yes, sir.
Okay, Achin, go ahead.
Yes, sir. General examination, patient is conscious, cooperative, well-oriented to time, place, and person, well-built and nourished. Pulse is 80 beats per minute. In radial artery, regular in rhythm, good volume. Blood pressure is 160 by 90. In right arm, supine position. Respiratory rate is 20 cycles per minute. Patient is afebrile. SpO2 is 98% on room air. BMI is 22 kg per meter square. Karnofsky score is 100. No evidence any pyloric teres, cyanosis, clubbing, lymphadenopathy, edema. Head to toe examination, spine examination grossly normal.
So BP should be checked in more positions, right? Or one or two arms, something like that.
What is the routine, Nalini?
Yeah, so BP, and again, there's a strong bias here because you are looking at the examination findings from urological perspective. At least check it in supine and in standing position to mark out the postural drop. Postural drop in a patient with pheochromocytoma is very, very strong sign. Okay, and that would help you. A hypertensive patient with a good postural drop of more than 20 in a systolic blood pressure is important. One. Two, I think you mentioned that the patient is on prazopress 10 milligram twice per day.
Yes, sir.
Yeah?
Yes, ma'am.
That is a patient again who's more prone for postural drop on prazopress as a drug, as a molecule, and that becomes one of the hindering parameter for you to escalate the doses. So that is one part you're absolutely going to watch out and you should be knowing about it. Okay.
Will I continue?
Please, would you like to continue, please?
Sure, ma'am. Local examination per abdomen. Patient examined in supine position with implied informed consent with exposure from nipple to knee in adequate room light. Inspection. Umbilicus is centrally placed. All quadrilates moving equally with respiration. No scars, sinuses, and ghost veins. Palpation. No local rise of temperature. No tenderness present. On deep palpation of the right flank, patient suddenly developed palpitation, perspiration, and patient felt uneasy. Bladder was not palpable. Percussion, tympanic node present all over the abdomen. Normal liver dullness span. Auscultation, normal bowel sounds present. External genitalia and all hernial orifices are normal.
So here what Dr. Nalini said is so important, that when you know and you are a urologist, you should not do this deep palpation.
Yes, sir.
Okay, fine. So just now next what?
So I would like to do general investigation and specific investigation. General investigation will include a complete blood count, a renal function test, thyroid profile, TSH, T3, T4 levels, and specific investigation would be do an ultrasonography of the abdomen plus pelvis, and with probably added Doppler, renal Doppler, and also check for plasma metanephrine levels, ensuring that the patient has when the patient has is already on prazosin, so prazosin would have to be stopped for a certain duration, and patient has to be, if any other drugs he's on, he has to be stopped. And when the blood sample is drawn for plasma metanephrine levels, the patient has to be as in supine position after 20 minutes of rest, and all the ensuring that all the drugs like tricyclic antidepressants, levodopa, everything is discontinued, which the patient is right now currently not on. And also like to check for serum cortisol levels.
Just ये सारा आप you will do all at once or you will have some sequencing in these investigations, or just in one paper you will advise and ask the patient to come for next visit with all these 10-20 investigations.
So a patient is actually having some he's having a history of headache, and he's having history of palpitations and perspiration on deep palpation of the right flank. So these are suggesting towards more like a adrenal secreting functioning tumor. So in this case, I would like to do investigation at the first visit, sir, along with a sonography, sir.
Why are you so sure this is a adrenal secreting tumor?
So there is a triad here, like patient has headache, episodic hypertension, and palpitation and perspiration.
Episodic, it's only on palpation, na? Palpitations.
So in the history.
Okay, yeah, you had that history.
Yes, sir. Yes, sir.
Okay, so you would like to, because of a history, you would like to go do all the tests at once. You will not go. You will not have any sequencing. Am I right?
So Mahendra, this case particularly history is very suggestive and biased.
Yeah. Mm-hmm.
So otherwise, if you have just a headache in a urological case presentation, it can be even a renal cell carcinoma with a paraneoplastic syndrome with hypertension.
Right, sir. Mm-hmm.
So here there are 2-3 things which are straightforward pointing you out to adrenal. So
okay.
So let us ask Dr. Nalini how you approach such patients.
No, sir. Either there is a history which is saying about water perspiration and those things. But if you have in a history like 35-year-old with only headaches and nothing else coming up, then all that examination, all for even, as I said, RCC is important. Any paraneoplastic can arise there.
Correct.
It can be a renin producing tumor also.
Fine.
Right. Again, I think Ojas, is that right? That's his name?
Yes, ma'am.
Yeah,
yes, ma'am.
Ojas, I really hope you don't mind being picked upon, but I think that you opted to be presenting. Maybe the questions are going to be directed to you. I think there are 2-3 things that I'd just like to point out as good practices and as something that you should remember even with your surgical career. Please understand that we are now kind of really getting onto the background of Pheo being a strong possibility. Please understand that when a patient with Pheo comes, irrespective of the current state of blood pressure, these patients can have very episodic and variable blood pressure right from low to high. Okay. So you do not want to stop their antihypertensive drugs abruptly. There is no reason to stop his prazopress before you collect the plasma-free metanephrines. And I'll just come to that bit a little later. So do not try to stop the antihypertensives. It's not going to change or compromise upon your results. That's what your worry is, isn't it? You don't want kind of a wishy-washy or hung sort of result, which is not allowing you to take a decision. So that's not going to be your problem, right?
Yes, ma'am.
Of course, if the patient has any of the antipsychiatric drugs on board, right from anxiety to whatever dopamine-related agonists that the patient may be on, those interferences are absolutely real and problematic, completely accepted. But it may not even be possible to take them out of those drugs, because you can worsen the whole psychiatric manifestation, which can also be very, very challenging for the patient and the family. So let us be careful to say which drugs are non-negotiable in terms of doing the test parameters and which drugs could be just allowed to remain on board because you don't want to destabilize your patient, right? Now, typically speaking, when you have a patient who presents with this degree of symptom complex, which is headache, palpitation, sweating, and these are episodic, and also on your examination, the symptom complex sort of temporarily worsen, which is Not a very happy situation, but it did happen and you registered it. So these are the patients where the metanephrines will be in a fairly high range, and none of your drugs will destabilize your interpretation of your values. Okay, so don't try to stop it. Go ahead and do the blood parameters, and then we will anchor the possible interpretation attached to it. Okay, because the implications of stopping drugs are huge. They're very, very difficult to work with. Okay, patients where beyond antihypertensives, especially the anti-psychiatric group of drugs, are on board, and you kind of really don't know how to wean them out of it or how to work around those areas of drugs, it's best to bring a psychiatrist on board and ask them to allow us a drug-free interval to interpret the parameters after blood collection more effectively. And that brings on forth the possibility of something which is a very highly suspected scenario of presence of pheochromocytoma, or something which is sort of more of, you know, anxiety, and everybody with anxiety, you, me included, who would go through anxiety and palpitation from time to time because of various reasons on board and so on, and somebody just starts putting Pheo on board, whether you know that the pre-test probability is so very low in those group of patients, your choice of test selection can become little different, little variable. That's what you should remember. So be careful of not destabilizing the pre-existing drugs if the patient is on that. Okay.
Yes, ma'am. Yes, ma'am.
Please do continue.
Nalini, when you see such patients, what are the investigations you will ask for?
So, you know, basically, if I had a patient who really, and actually you have to realize that by the time the patient lands with an endocrinologist, there are enough filters which have gone on board and enough consults which have gone on board as well. So these are the patients who will come to me for two reasons. One is a young hypertensive, like a 30-year-old, where somebody is trying to find out a cause for a secondary hypertension, and endocrine causes really reign very, very high over there. And that's why the patient would come to me. And second is a reason where, because of imaging which has been put on board by anybody, an adrenal mass has been picked up, and then an endocrine consult is generated to ask what kind of mass is it in terms of its secretory, non-secretory nature, its nature otherwise in terms of being benign, malignant, and possible delineation of its all endocrine functional aspects, and pre-operative preparation if at all the surgery is being planned. So these are the questions under which I deal with in these masses. And if I have a hypertensive individual with actually adrenal mass on board, where if my clinical assessment does not give me a clue to say that there is an associated Cushing, which comes from adrenal cortical masses, then I will be inclined towards going for medullary masses, even if it is a stable hypertension. Even if there are no other associated paroxysms, I will want to anchor that and rule it out. But please remember, by that time, if the imaging is already done and it is available, even imaging being interpreted appropriately is a huge deal of information which should never be overlooked. It can give extraordinarily informative differential diagnosis in these group of individuals, and that becomes sort of the division line starts from cortical mass, A, adrenal mass, B, cortical versus medullary mass, and in cortical what are the possible differentials, and in medullary what are the possible differentials, and so on. So please, Ojas, please continue.
Yeah. So, Ojas, what are the investigations now you will ask for?
General investigation, specific investigation. General investigation will include a complete blood count, renal function test, thyroid profile, TSH, T3, T4, and ECG, 2D echo, probably. And specific investigations could include an ultrasonography of the abdomen plus pelvis, and urinary, plasma-free metanephrine levels and serum cortisol levels.
Okay.
Okay. So one question, Nalini madam, if we want to ask a clinical diagnosis at the end of this history and examination, we can go directly to probably a Pheo or a extra-adrenal Pheo?
The paroxysms, the way Ojas described it,
right,
and the way he kind of elicited on palpation makes Pheo a very strong contender. Pheo, PGL being one family, and I'm not trying to distinguish right now without imaging available to me between the two. And both of them will become my strong kind of possibility
Ojas
that
and the other one,
anchor.
You remember, so if anybody asks your clinical diagnosis working, it will be a Pheo, adrenal or extra-adrenal, anything. Extra-adrenal is PGL.
Yes, sir.
Yeah. So continue with that. So Machint, kuch dikhana hai test?
Yes, sir.
Yes, ma'am.
Or just as endocrinologists, we are very, very sensitive people. And if you just throw a serum cortisol in our face like that, we will throw it right back at you. Okay.
Okay.
You don't talk about serum cortisol as a random number. You know what I mean? It's extraordinarily pertinent to the time of the day that you collect the blood sample, the kind of stress that the person is going through, and so on. There are many more variables attached to it beyond the secretion from the adrenal cortex, which will change your interpretative value attached to cortisol as a number. So you want to be a little careful, and you'll not just put it in one basket, cortisol, you know? So careful.
So
can you just explain them?
Don't say serum cortisol, right?
8 a.m. morning 8 a.m. serum cortisol levels.
But again, you know, okay, let me put it this way. I give you a serum cortisol value, which is 5 microgram per deciliter. I give you another value, which is 20 microgram per deciliter. What does it mean to you?
Simple question. What is purpose of sending the serum cortisol? What make you to send the serum cortisol in this patient?
Means on examination, we didn't have any cortisol like
clinical history or any examination which suggests that this patient had probably Cushing syndrome.
There was nothing.
Or increase in cortisol. Only any weight gain, any central obesity, any diabetes, any hypertension, any depression, anything is there, gene, skin problems, any hypokalemia, already you are not sent till time. ऐसा कुछ तो चीज है जिसको हम एक्सपेक्ट कर सकते कि इसमें there is a chance of having a Cushing, and that's why I am sending the serum cortisol.
Only hypertension.
This thing is there.
Only hypertension, nothing else. Only hypertension.
So only hypertension, then 1,000 causes for hypertension.
Yes, sir.
High cortisol only.
So again, Ojas, even if sort of you were suspecting sort of, you know, adrenal cortical mass and you were kind of looking at cortisol dynamics, please remember that your basal cortisol by itself is probably not possible to interpret. You give me a value which is 4 microgram and a 20 microgram, it means the same to me. Okay? So by itself, it may not have a value attached to give you a direction to say what does it mean and which way you should be moving forward. It doesn't work like that. So if you are thinking of any aspect of adrenocortical mass and you want to work with cortisol dynamics, cortisol assessment is done only by dynamic testing, which means that I need to either do cortisol, ACTH, DHEAS, overnight DEXA suppression, and many more other things, which maybe Some other time we can anchor, otherwise we'll deviate so badly from your current scenario. So just, I want you to be sensitized about this, that it is not just do cortisol, it has got its own ramifications which need to be addressed before you work with the level. Okay.
Okay.
Fine. Okay, Achin, just show them the results.
Yes, sir. Hemoglobin is 12.4, count is 8,000, serum creatinine is 1.0, urine RM shows RBC is absent and WBC is occasional. USG report film is not available. Report shows bilateral kidney normal in size, shape, CMD well maintained. Right adrenal mass lesion measuring 7 by 5 centimeter with central areas of hypoechogenic density, query hemorrhage. Bilateral ureter normal, bladder partially full, prostate is 15 grams.
So just what about CT scan you will ask for?
So I will like now the UA based on the history and the examination findings and the sonography suggestion for right adrenal mass. I would like to do a CT triple phase contrast CT with adrenal protocol, in which I would like for the early arterial venous and the late delayed venous phase of 15 minutes, along with reconstruction according to adrenal protocol, and then have a look, sir.
What is the protocol?
So adrenal protocol is you take a plain film, then you take the early arterial venous and the delayed phase of at 5 and 15 minutes mainly, look for the washout, and also we take 3 millimeter cuts at the level of adrenal with the region of interest being the adrenal more than 50% in the imaging being visualized, and 5 millimeter reconstruction plates.
So now tell us what is the importance of plain CT and followed by contrast. So what are the interpretations?
So in plain film, we first look at the dense. First, in the plain film, we look where is the lesion mainly, what is the density of the lesion, the location, and we calculate the Hounsfield unit of that lesion, whether and what is the nature, whether it is heterogeneous, homogeneous. And after the plain film, then when we take the other after
what is the importance of HU?
Sir, in cases of adrenal, if the density is less than 10 Hounsfield units, that is it is so it is more likely to be an adenoma, but that will be further confirmed by doing a contrast and a delayed washout phase. Whereas in other lesions like pheochromocytoma, the density is generally around 20 to 30 Hounsfield units. Even in fat poor adenomas, the density will be slightly more than 10, like around 10 to 20. And in myelolipomas, again, the density will be somewhere between 25 to 30. And hemorrhage, the density will be around 30 to 40 Hounsfield, sir. Adrenal hemorrhage or adrenal hemorrhage. And then we calculate the absolute percentage washout and the relative percentage washout, that is for an adenoma. That will help to distinguish whether it's an adrenal adenoma or not. Whether absolute percentage washout more than 60% or relative percentage washout more than 40% is highly suggestive of an adrenal adenoma.
Okay. Nalini, you want to guide them or tell them something more? Any information?
Yeah. Ojas.
Yes, ma'am.
Ojas, I think you should sort of have this. It's one thing to talk about what did you look for in the basal cut, which is unenhanced films that you're looking at. And it's a second thing to tell me how you're looking at possibility of a benign versus malignant lesion in terms of its washout. Yeah.
Yes, ma'am.
Pheo has extraordinarily typical characteristics on CT scan, and that is something that needs to be brought out by your comments. And that is one thing that needs to be sort of highlighted because you are the man who has been referred a patient with adrenal lesion, and just looking at the CT scan, you should have said, this is Pheo, and there is absolutely no differential diagnosis to it, you know. Even if I try to shake you out of it, you cannot budge from it. That how strong the CT characteristics are. And you should be very conscious about it. Pheo also has a poor washout characteristics. Please understand this. And it's a completely benign lesion. It's very uncommon for Pheo to be malignant. Don't talk about it right now because you're just beginning the discussion of Pheo, right? So the question is, how does Pheo differ with its poor washout characteristics from other adrenal masses which are not benign and have poor washout characteristics? What do you think?
The density will be somewhere around 30 to 40 ounce units. And
what
there
density
is
are we talking about?
The HU of the lesion.
HU, which is basal or arterial or venous or delayed?
The basal will be around 32.
I mean, I can have an adrenal carcinoma which will look like that. I'm sure Dr. Ganesh will agree with me because he has referred, I mean, practically all our adrenal carcinomas have come from him.
Right, ma'am.
It's not the basal HU which helps you, Ojas. What actually helps you, every single adrenal lesion with a poor washout characteristics, you take adrenal carcinomas, you take pheochromocytomas, or you take sort of, you know, even unusual adrenal masses like adrenal lymphomas, which we've seen thanks to Tata Hospital. You need to realize that these patients have extraordinarily peculiar characteristic of percentage arterial enhancement. They're extremely bright on the early arterial phase, which is not like any other poor washing out masses. Typically adrenal carcinoma, it'll never have such a bright arterial enhancement value attached to it. And most of the arterial enhancement in Pheo, percentage arterial enhancement is almost to the tune of 100%, literally. This is published data from our department, and I truly suggest that even if you don't have time to read the full article, at least read the abstract of it for just your orientation to say how powerful it can be, because not all the adrenal masses are assessed with early arterial phase. Routine evaluation of adrenal masses is just basal and venous or delayed films most of the time, right? So arterial enhancement is something which is extraordinarily helpful, is something that you need to know, and it sets them apart from other poor washout masses. Okay, so I just want you to remember this fact and, you know, perhaps sort of assimilate it after you've read the article that is published.
Okay, ma'am. Yeah. Yes, ma'am.
Yeah. Fine. That's a Achin, show them all the films.
Yes, sir.
Or just you want to say anything, or we should directly see the report?
Yes, sir. So initial films, the plain films. Again, can you show the plain films? Plain. Yeah. This is a contrast. This is a plain films of the abdomen axial sections in which the liver is normal, spleen is normal. In the right suprarenal region, a heterogeneous mass is seen with a higher density. Heterogeneous mass is seen with higher density on the rim and central hypodensity. Hypodensity in the inner part. There is both kidneys appear normal. So I'd like to see the contrast films. in the contrast field, the liver spleen is normal. The kidneys are both kidneys are normal. The right suprarenal mass has a peripheral rim of enhancement with central hypodense area with low density, and this is early arterial phase, I think. Yeah. The rest kidneys and everything is normal. No any lymph nodes or any other enlargement. Yeah, the tissue planes with the masses are clear. With the liver and surrounding structure, it is clear. The tissue planes, fat planes appear clear with the mass. The upper part. Yeah. Yes, sir.
Okay, Achin, just show them the report.
Should I read it out?
Yeah, please read out.
A large heterodense mass lesion measuring 7.5 into 5.7 into 6.4 centimeters seen in the right suprarenal region. Mass shows central hyperintensity on the plane scan with isodense periphery. Post contrast, there is a thick, intense enhancement of the periphery on venous face and significant washout on 15 minutes delayed scan. Large central core of the lesion shows no enhancement, may represent necrosis or chronic hemorrhage. No intra-lesion macroscopic fat is seen. Two tiny punctate foci of calcification measuring 2 to 3 mm in size are seen along the posterior superior margin of the mass, and another tiny calcific focus along the inferior lateral margin of the mass. Perilesional fat stranding is present. The right adrenal gland is not separately seen from the mass lesion. Mild mass effect is present on the IVC and superior pole of the right kidney. No invasion seen into the adjacent structures. And HU value is as it's shown here.
44. Okay, absolute washout is contrast minus plane. That is 128 minus 44 will be 28 means 60 is 84 upon 61. So around 84 upon 60. 50.
Yes. So just what is your
Sir,
take on this?
Okay. So also about the metanephrine levels. So what are the metanephrine levels? They were done. So metanephrine levels.
No, just may I stop you right there, please?
Yes,
For just one tiny second, I just want to point out one or two things on the report so that there's a little kind of, how do you say, it registers better since you are anchoring the whole show. I don't want to know who's reported this, but there are things which are out of context, which I want you to notice, understand, and sort of see to it that we don't repeat such mistakes, okay? It says that possibilities include a large lipid poor adenoma with internal necrosis or a chronic hemorrhage. You don't get adenomas with necrosis like that, okay? That itself will put me off so badly that I'll never be able to call it adenoma. I wouldn't have courage to call it adenoma with such huge areas of necrosis sitting over there, because by nature, adenoma are such a benign process. They should not outgrow their blood supply or go through necrosis like that, okay? So that's a very poor statement to work with. Chronic hemorrhage and adrenal cortical carcinoma. Now, carcinoma is in view of large size, heterogeneous content, and the enhancement pattern. There's so much of contradiction in this wording of the report, which is what I want you to notice. Large size by itself does not take you for or against Pheo. It doesn't. I can have a Pheo which is 1 centimeter or few millimeters, or I can have a Pheo which is 10 centimeters, all right? So it never takes you away for or against Pheo or for or against. It makes adrenal carcinoma less likely to be in 1 or 2 centimeters, yes, but the size, which is large, just never takes away pheochromocytoma, okay? Notice the arterial enhancement value of 128 HU. You cannot get that kind of a value with adrenocortical carcinomas. It's extraordinarily uncommon to get that, okay? So again, there is a huge contradiction which is built into this report. And that is one thing which always tells you, you have to read your own radiology. You have to, because see, ultimately, you know the patient and you kind of will know tomorrow the histopathology also for you to go back and look at the, sort of interpretations attached to the radiological picture. Always remember on radiology to comment and notice and register the opposite adrenal. Commenting that the opposite adrenal is completely normal in shape and size is very important to me. Typically, in adrenocortical carcinoma, I'll see the opposite gland, which is very tiny and kind of almost shrunken or shriveled up. And that happens because of multiple reasons, really. Okay. And in Pheo, I'm very keen to know the opposite gland because I could have beginning of Pheo in the opposite gland, which is very important to me from patient's point of view to say, how am I going to manage this patient who possibly has bilateral pheochromocytoma? Okay, so you will kind of register these parameters. Yeah, please just continue.
Yeah, thank you, Nalini. Okay. So these are the values.
Yes, sir.
Yes.
Miranka.
Yes, sir.
Is there any importance to achieve value on plain film?
Sir, low lipid points towards more towards pheochromocytoma, and Hounsfield.
Lipid richness can presence of intracellular lipid or lipid richness inside the tumor, can it be judged on non-contrast CT scan?
Okay.
So the question initially asked by Gaurang Shah sir is what are the findings in non-contrast CT scan? So non-contrast CT scan calcification can be judged, size can be judged. HU on non-contrast CT scan, if it is less than 10, then there are chances of having a lipid-rich adenoma is very high.
Yes.
So you should ask for the HU value, na? If there is a central necrosis, if size is more than 4 centimeter, if there is irregular mass, then if there is any heterogeneous mass, these all things can be judged on the calcification inside. These all things can be judged in non-contrast CT scan. So differentiation from adenoma with rest of the diagnosis of adrenal, it can be judged with non-contrast CT scan. Confirmation of is it really adenoma is definitely with, again, contrast CT scan. It is absolute washout and relative washout. It should be more than 60 and 40.
Yes.
So ये आंसर आपने नॉन कॉन्ट्रास्ट CT स्कैन का क्या यूज है ये पूछते समय बताना चाहिए.
Fine. So now these are the values. So
Yes,
Mriganka, now next what?
Sir, I would like to also do urinary metanephrine.
Why?
24 hours, sir, to confirm the diagnosis.
Mruganka, but with all that thing, the diagnosis is staring at your face.
Yes, sir.
Sir, the diagnosis is yes. Yes, sir.
So there are features of kind of suspicious lesion, could be malignancy also. So
based on the likely diagnosis is pheochromocytoma over here. This points in the favor of pheochromocytoma. First, in the history, the patient complains of headache, which is the most common symptom in pheochromocytoma, 70 to 90% cases. The patient also reports a triad, that is headache, perspiration, and palpitations. In examination findings, there is increase in palpitation and perspiration on deep palpation in the right frank region. Also, in further workup in the USG, we can see a large.
Okay, Ojas, but what are you hinting at?
So a pheochromocytoma, sir, because
okay, so if your triad was missing in this thing, and on deep palpation that perspiration or tachycardia would not have happened after these investigations, what is your diagnosis again?
so based on the levels of free metanephrines and
it is few only.
Few only, yes, sir. Few only, yes, sir.
Yeah, so the question next is, what will you do next? So simple thing, do you want to do a urinary VMA now?
No, sir.
No, I don't want to waste money and time.
No, sir. It is more likely
it is given up after plasma free.
Yes, sir.
So we can do genetic workup because the patient is 30 years. So is it required? Or straight away we can go for pre-operative management?
So let us ask Nalini. Nalini, now what is your say on all these things? For example, when you do urinary metanephrine, or is it indicated, not indicated, any other investigation is indicated? Please, explain us.
So I think this plasma-free metanephrine value that you have is sort of fairly good, and I don't think you need any further investigation unless A, patient was not lying down when this blood sample was collected. B, patient's blood pressure was externally uncontrolled. He was very anxious. There was something wrong with the patient, like an acute cardiac event or acute complication of hypertension during which this blood sample was collected. If any such parameters are associated with this blood sample, I may not be able to interpret that at all. But otherwise, in a patient who's relatively stable and the patient's sample, which is collected in supine position, this is pretty good for me to be saying that there is a fairly good chance of it being pheochromocytoma. Putting together additional urinary parameter is not going to enhance the value addition to your diagnosis or information generation for your management. It's absolutely unindicated. If you had a concern and a question related to this value, you are better off repeating this value again in proper conditions. That is fine. Like posture, cold chain storage, cold chain transport. If you want to adhere to all that and ensure it, do it again. We have absolutely no problem with that. But you cannot go from plasma to urine. It's completely arbitrary, and you do not need urinary values as any piece of information for diagnosis or for management. So forget about that.
Okay. And what about this genetic he was talking about?
Yeah. So I don't know who mentioned it. Mriganka mentioned it.
Yes, ma'am.
Yeah. Mriganka, I'll give you whatever genetics you want. What will you do with it? I'll tell you the genetic is positive and this genetic is negative. What does it mean and how does it help you?
Mriganka, you can answer.
It's just okay, ma'am.
So you're just
for management of this particular case, it should be different. At the most, if you are stretched up with that question, you can say, it will help me counsel the family, whatever.
Yeah.
So, but it's not a nice thing that after coming to such a good conclusion, you are saying, now I'll go back and do genetic testing. I mean, we'll do. We had in history, we didn't get any family tree or family history positive. So it's okay once in a while. Secondly, there are few questions. Would you do an FDG PET scan? Would you do an MIBG scan? So answer for all of them. And in case, when would you have considered doing an MRI?
Yes. Ojas.
So the mass size is more than more than 6 centimeters, 7 centimeter. There are chances of it has to be ruled out whether it's a malignant pheochromocytoma. So FDG PET would be utilized if to know whether it is malignant, if there are any METs which would show an activity on a FDG PET. Similarly, MIBG scan. For a MRI, it will be useful if so MRI, I'm not sure, sir.
Yes, Ganesh, you can tell them.
No, I mean, generally we do a CT scan with all those features you already discussed. MRI is a little more specific to a few. We did not repeat it, but MRI shows a classic light bulb appearance. That much you should
Light bulb,
know.
yes, sir. Light bulb, sir. Yes,
And
sir.
and MIBG we usually don't do in the beginning. So I think we'll take madam's comments on that, but MIBG is never done in the beginning. It may be done sometimes if post surgery, if you have done a complete clearance, so called, and then even then the BP hypertension sustains. Probably that is the time for an MIBG.
So,
or MI.
sorry.
Yeah, ma'am. Sorry.
Sorry.
I'm sorry.
No.
No,
I'm
I
so
was,
sorry.
I was
Please
waiting
continue.
to listen to you.
Hold on. Right. So, Briganka and
Yes, ma'am.
Otis.
Yes, ma'am.
This is the way I would structure my thinking around functional imaging in a patient with suspected pheochromocytoma. Okay. What is your actual question here? Are you trying to reaffirm and reconfirm the diagnosis of pheo with functional imaging? Or are you trying to look at a possibility of it being multiple in origin? Or are you trying to ask yourself whether it could be metastatic, and that's why there could be more than one lesion that you surgically have to deal with? Okay. These are the basic three questions that you want to answer with functional imaging. And that will also decide the kind of functional imaging that you will deal with. Typically, the functional imaging that you have, as Ganesh mentioned to us, is MIBG. You have a DOTA as well. You have an FDG. These are the three scans that you want to deal with. And how do you kind of really position these scans for yourself? Okay. Now, please understand that if you are kind of questioning the diagnosis of this mass being actually pheo, even your biochemistry is sitting on a fence or anything like that, in that case, you want something which is very specific, which is only taken up as a tracer uptake by pheo and no other lesion. You want to enhance the specificity of your diagnosis, right? Not sensitivity, right? In that case, you may consider doing MIBG or DOTA. That's fine. I get a DOTA avid mass or I get a MIBG avid mass, I know that I'm dealing with pheochromocytoma. But please understand the caveats also. A normal adrenal gland can pick up MIBG, completely normal adrenal gland, okay? And it'll light up over there like one nice light bulb sitting over there. So MIBG uptake in absence of a mass lesion has got zero value. It has no value whatsoever, is what you need to remember, okay? DOTA, whatever is the size of the lesion, it is size specific. So smaller the lesion, you can miss it with DOTA, but generally it's not common to see pheo, which is less than a centimeter, unless it is part of the screening process in a genetically predisposed individual. Understood? So then DOTA is also a very specific set of investigation. But when I'm talking about multiple origin, there are certain genetic conditions where it could be more than one lesion of pheo and paraganglioma, or multiple paragangliomas that you may see in a patient. There, again, your DOTA will be very helpful. But if there's a malignancy which is suspected where you want to look at metastatic spread, you may need FDG PET also, because some of the dedifferentiated tumors will not pick up DOTA. Do you get this picture? Do you get the rationale about it?
Yes, ma'am.
Yes.
Sure.
Thank you for such a nice explanation. Yeah. So now, Ojas, you have come to this conclusion. Now, next what?
So now the patient has to be counseled that he has a pheochromocytoma and that needs to be removed. And the patient has to be explained about what are the prognosis associated with the same, what are the steps which has to be taken pre-operatively to manage the same, and what will be the follow-up of the same. Also, a cardiologist opinion would be sought after, and an endocrinologist opinion for management of the symptoms associated with the pheochromocytoma. After the patient and the relatives have been counseled regarding the nature of the disease, the patient is already on prazosin alpha blockers. We'll also, after the alpha blockers, we'll also like to start the patient for his palpitations. We can start on beta blockers, either propranolol, metoprolol, or atenolol. And some institutes would also go ahead with metyrosine as a tyrosine hydroxylase inhibitors, which is this all is started. So the alpha blockers started around 1 to 2 weeks before surgery. In prazosin has been already started here. Prazosin or phenoxybenzamine could be used. The beta blocker, which is after alpha blockade, we started beta blockers, which is started around 2 to 3 days after considerable alpha blockade effect has been observed. And we started metyrosine and calcium channel blockers. Also, the patient is advised to increase his water intake and fluid intake. Pre-operatively, the patient will be admitted around 2 to 3 days before the surgery, in which he will be increased salt intake and fluid intake. And on the morning of the surgery, the alpha blockade would be stopped. The patient would be given an IV bolus of fluids around 1 to 2 liters, and then the patient would be taken for surgery. During the surgery part, there are certain steps which are important just before the surgery, during the surgery, and after the surgery. Before the surgery, the thorough communication between the surgeon and the anesthetist regarding the steps during the surgery. Also, the anesthetist would be not be using desflurane in this case, and halothane is anyways not used, but desflurane and halothane are the agents that should be avoided. Also, the anesthetist should be ready with labetalol, nitroglycerin in case hypertensive crisis develops. And also with steroids in case hypotension develops after removal of the tumor. Now, during the surgery part, there should be less handling of the tumor. Before clamping of the adrenal vein, the anesthetist should be communicated with, and the anesthetist should be giving a good preload of volume so as to prevent hypotension. After the adrenal is removed, it should be bagged and removed. In that scenario, the blood pressure has to be looked upon. There is sudden hypertensive crisis that should be managed by labetalol and nitroglycerin. And if there is hypotensive crisis, steroids will be given. And yes, sir, and the post-operative period would involve monitoring of the blood pressure and yes, sir, monitoring the blood pressure and yes, sir, mainly the monitoring of blood pressure.
Okay, so Nalini, can you just guide them? Because see, we are seeing very less PO, and many of the students, they might not have seen, they don't know actual preparation. This is all what they have read in the book. So can you just guide them how you will advise?
Okay, so please understand, basically in Pheo, you're trying to correct the physiology which has gone wrong, okay? There is hypertension, which is because of alpha receptors which are stimulated, the beta receptor which are stimulated to give you palpitations, and there is a volume depletion in Pheo patients, okay? So what you need to do is give them alpha blockers, right? And as you start with the alpha blockers, you will notice that the palpitation can become problem in certain group of patients, and you will need to introduce beta blockers. In addition, along with this preparation, as it is ongoing, volume will have to be attended to, in which happens with salt institution and also with fluid as institution, okay? So salt we generally give in terms of giving salt capsules to these patients, and you may require anything up to 2 to 6 grams of salt per day, Okay, so we just prepare the salt capsules and give it to these patients. Tell them to drink water, minimum of 2.5 to 3 liters per day. And before the surgery, the prior evening, they are given a fast infusion of saline, 1 liter intravenous. Okay, alpha blockers, in terms of drug preference, I think OJS seem to be putting together to say that whether you can use prazopress, whether you want to use phenoxybenzamine. Understand that phenoxybenzamine, prazopress, doxazubicin, all these are alpha blockers. There was very kind of a, how do you say, very strong case which was made for phenoxybenzamine as a hero. Okay, till a randomized study came out, which is published I think in 20 or 21, I'm sorry, I don't remember the year, but it very clearly said there is no difference between phenoxybenzamine and just selective alpha blockers. You know that phenoxybenzamine is a non-selective alpha blockers, and drugs like prazo are very selective alpha blockers. There is no difference in the outcome of A, degree of hypertension control, B, degree of hemodynamic instability during surgery, and C, with phenoxy, post-operative hypotension can be more marked and prolonged compared to selective blockers like prazopress. Okay, so it doesn't matter. And also understand, in India, it's not easily available, phenoxybenzamine. Even if it is available, it is expensive. Okay, and typically institute like ours, like KM as my background, if I give an example of, we try to work with what is available in the institution. So it is free of charge for the patient. We have always worked with prazopress as our alpha blocker. Till such time, we realized that in these patients, when you treat them with prazopress and you kind of control them, you still had a huge element of surprise intraoperatively. Like, for example, a well-controlled hypertensive patient intraoperatively becomes very, very unstable. A normotensive preoperative individual who never had hypertension suddenly starts becoming very, very labile hypertensive intraoperatively. So there is an element of unpredictability during surgery, especially at the time of intubation, at the time of intra-abdominal air insufflation, and at the time of handling the tumors. These are the 3 time zones when the blood pressure instability or hemodynamic instability is very huge. Okay, with that question and concern was born the question to say, can we use, instead of these drugs, calcium channel blockers per se? And in our department, we had done an RCT. The result of that is published in May of 2021 in a very high impact journal. And please just take a look at it, or just, if you don't get time, just read an abstract, but read it.
Yes,
Okay,
ma'am. Yes, ma'am.
it's something which is very Indian in origin. It's an original work, one of its kind in the country. And what you need to know about it is that when we had 2 groups of patients, prazopress and calcium channel blockers, and these are randomized patients, okay, it was seen very clearly that hemodynamic instability is much less, much less than with calcium channel blockers. They have an extraordinarily smooth intraoperative and definitely postoperative outcome in terms of hemodynamic excursions of blood pressure or hypotension postoperatively. Okay, and that's how today calcium channel blockers, after this RCT data, has become drug of choice for us. Do you get the picture? So
Yes,
I
ma'am.
just wanted you to know.
Yes, 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 yes. Fine. So, Ojas,
Yes, sir.
will you suggest anesthetist to do something more?
So the preload volume should be like
No, that
yes,
you have
sir.
already done during the anesthesia. Which are the lines you will ask him to?
Arterial lines for blood pressure monitoring. Yes, sir. Arterial line would be must for a blood pressure monitoring. Yes, sir.
And what are the complications you are anticipating?
So sudden hypertensive crisis, sudden hypotension post removal of the adrenal mass, and bleeding, sir.
So in the hypertension, what are the complications?
So with sudden hypertensive crisis, the patient may have a stroke or this is mainly a neurological complication, stroke or so bleeding, sir.
Yeah, so mainly the stroke.
Yes, sir.
So Ganesh, can you just tell us what are the complications you have come across or which are possible?
सर थोड़ा ना ये अनस्टेबल है इंटरनेट.
हाँ तो अपना ये है ना, anyone can answer ना.
Okay. So may I answer?
Yeah, Mahendra, you answer na.
Yeah. So when intraoperatively there is sudden rise in blood pressure, so as you just said, there is an unrecognized stroke that will only come after the extubation, and maybe if you are halfway through the surgery, you may have sudden diffuse oozing from the operative bed, right? That can, in laparoscopic at least, it is very difficult to proceed further. So in that stage, you just have to stop the procedure, pack the bleeding site, and ask anesthetist to lower the blood pressure, and then again proceed. So this is the the steps which you should do while operating. And about the hypotension, I just said is a hypotension when we ligate the adrenal vein, right? But it doesn't happen. But it does not happen always, because there's a many times the collaterals capillaries around through from the mass to the systemic circulation. So even if you ligate or clip the main adrenal vein, sometimes when you mobilize on you dissecting the mass, again there is a BP fluctuation, right? So again you have to be careful, and every step BP rise, you have to stop, then ask not to normalize the BP and then proceed. Okay.
Right.
Yes, sir.
Yeah.
Okay. So how, Ojas, how
Yes,
will you follow up this patient?
So post-operatively, the patient would continue to have blood pressure monitoring.
Fan
Blood pressure. Yes, sir. Yes, sir.
Ganesh, you were saying something.
No, sir. Sorry.
Yeah.
Sir, I want to ask something from Ojas. Gaurang
Yes,
Shah, sir. How will you decide about the approach? Open or minimally invasive, and what are the indications of various approaches?
So in this case, I would go ahead with the open surgery, sir. Open approach.
Why not lap? Why not lap? Margins are smooth, and no adjacent organ involvement. Only size is something maybe 6 centimeter, 5 centimeter.
So as a, I would, sir, if I am the operating surgeon, sir, as initially in my initial phases, I would be more comfortable with open surgery. However, laparoscopy could also be indicated
Very
in this
good.
procedure. Yes, sir.
Very good answer. Very good answer. Fine.
Yes, sir.
Fine, but that can be also done by minimally invasive, right?
Yes, sir. Yes, sir.
So in which cases you will not go for minimally invasive?
In case of a malignancy, because the chances of peritoneal seedling and port site seedling of the malignancy is higher if you're using in case of carcinoma. Second thing, if the planes are disturbed, the fat planes are disturbed with the surrounding, the mass with the surrounding tissues, then in that case you would not prefer. And the huge size of the mass. Similarly, with disruption of the fat planes with the adjacent tissues.
The other thing, wherever the possibility of achieving resection R0 is not possible.
Yes.
Okay.
Yes, sir. Yes, sir.
That also you should not go with the minimally invasive surgery.
Yes, and also
Okay.
contraindications for general anesthesia, contraindications for lap surgery,
That is the common indications. I am not
yes,
specific about the
yes, sir.
adult mass. Okay, fine. Ganesh, anything else want to add?
No, Mahendra, all is good.
Okay.
So technically,
now
lab
about
for a few lab turns out, or a
Yeah.
minimal invasive surgery turns out very much good. So, Ojas, if you are planning open surgery, what will be your incisions?
So in this case, it's a large mass. I would like to go ahead with some midline incision, sir. So 7 centimeter mass, midline incision would be preferable.
Any options?
So a flank incision would also be preferred. But midline would be preferred in this case. It's a large mass, 7 centimeter, with compression of the surrounding IVC, and also so a midline would be preferable in this case.
So we already have the CT. Can we take a subcostal chevron type incision?
So we can take a chevron incision. Yes, sir.
We can take it. It's a single mass.
Yes, sir.
Right
We can take a
sided.
chevron. Yes, sir. Yes, sir.
So right chevron ka we can take going a little bit on the left, not the complete left.
Yes, sir.
Ojas,
Yes, sir.
thoraco-abdominal extrapleural versus half chevron versus midline.
Barabar.
So midline would be preferred if you are suspecting numerous, very large and invasion of the IVC and.
By taking midline incision, how much retraction you will require?
Tremendous. So if it is a PGL where there are 4-5 masses, midline would be slightly better, but will require a big one.
In the kidney, upper polar mass, big mass, you are planning best your answer to thoracic abdomen.
Thoracic abdomen, yes, yes. Sir.
And why it is now for adrenal it is midline? Same site, it is proximal to the upper pole of kidney. Big size mass. Again, chances of getting increase in pressure intraoperatively by retraction handling is more in the midline. If you want to dam on the top of the mass, or you want to retract the abdominal wall and then mobilize with fingers here and there retraction, which will be better?
So we have to have minimum handling of the mass. So
handling is minimum with chevron and extra pleural thoracic abdominal or midline?
Midline, sir.
Extra.
Not sure.
Thoracic abdominal.
Let me put in another way, Ojas.
Yes, sir.
If you have a very good exposure of the operative field, then you will have a minimal handling, or when you have a suboptimal exposure, then you have a minimal handling. In which scenario you will have minimal handling?
Minimal handling when we have a good exposure.
This good exposure. So out of the Gita also only wants to know in midline or in chevron or thoracic abdomen, which approach will give you the good exposure.
I think thoracic abdominal is actually thoracic abdominal.
Because you yourself is contradicting to your answer. You are telling thoracic abdominal for upper polar renal mass, and you are telling adrenal mass to midline.
Yes, sir. Thoracic abdomen. Yes, sir. Yes. Understood, sir. Yes.
Yes. So that will be the preferred one, no? And you are routinely, see, we are routinely doing thoraco-abdominal with that intercostal or costal incision. So we are very well versed with the anatomy and everything. So as a urologist, I think we also expect that you will be well versed with this incision rather than, and we have tried many times. Onco surgeon, yes, or general surgeon, they prefer midline. but we usually prefer flank incision.
No, no, sir. Extrapleural thoracoabdominal you can inside the thorax and you can extend inside the abdomen as per
Exactly.
the requirement.
Yes, yes.
So that will be the best incision for big adrenal tumor when you are going with open surgery.
Yes, sir.
Yes, yes. Okay. So, Ojas, now you have finished the surgery. Patient is okay. How will you follow up?
So I would like to follow up the patient with like the metanephrine levels initially on 3 monthly basis, and if there is and also the blood pressure monitoring. So if there is a persistent rise in the blood pressure and if the metanephrines are high, then I would like to further evaluate the patient for either whether the patient has had like residual disease or there is another site for the production of the metanephrines.
So, what investigation you will do?
So FDG PET or a CT scan, sir. FDG PET. That will
Yeah,
show
you have already done CT scan earlier.
FDG PET, sir. FDG PET scan.
Nalini,
Or an
can you
FDG.
Nalini, can you just tell us how to follow up and what are the important points?
Yeah. So, again, Ojas, I'd just like you to consider a few things that we need to put together in our brain before we decide a monitoring plan for this patient. The first thing is that this is a metanephrine secreting mass lesion. Okay. When you have a metanephrine secreting mass lesion in a 30-year-old male that he is, and the CT scan which showed that on the left side also, which is reportedly uninvolved, there is a nodule of about 7 or 8 millimeters, which I couldn't see on your CT scan, but that's what your report reads as. My first worry would be that I'm dealing with bilateral pheo, and the second pheo is still, it's being, it's happening. It's not already happened as a big lesion as of now. When I have a metanephrine secreting tumor mass, I am worried about MEN2 syndromes, 2A or 2B. And I would be more worried than even Pheo about their medullary thyroid carcinomas. It's not likely to be 2B because the faces are so typical that everybody should recognize them in terms of there being a possibility of meant to be. They're extraordinarily typical faces. And even if you've seen a book picture, you can't miss a patient, really speaking, right? So if it is meant to A, I'm worried about medullary thyroid carcinoma not being missed. And I would like to know calcitonin in this patient also, to make sure that I have completely looked at the disease burden and manage my patient effectively. I'll manage the pheo very well surgically, but he will have spread of medullary thyroid carcinoma because that has gone unchecked and unattended, and that cannot happen to your patient. So I would be worried about that part of the story. So having ensure that this is an isolated pheochromocytoma that you're dealing with, I would do following. I would first sort of make sure that this surgical process that was done for this patient has definitely helped the patient. And that I would come to know by monitoring the blood pressure, by monitoring the biochemistry. Sometimes the blood pressure in certain groups of individual may not normalize, especially if it has been long uncontrolled phase of hypertension that the patient has suffered, right? In which case persistence of blood pressure doesn't mean persistence of tumor, and I may have to fall back on my biochemistry to tell me whether or not the patient has persistence of the disease process. So I would be very, very careful about that. Okay. If I have no hypertension, then it's very unlikely that there is any persistence of the disease that I'm really dealing with. But because this man is young, I would request them to consider genetics in the patient, even in absence of family history, because many a times we've seen that it's only going back after making complete diagnosis in this patient that you understand the other family members did have other components which were not sort of tied up together to give you the completeness of the diagnosis. So I would offer them genetics for the pheochromocytoma also, because the yield is pretty high. It's a fairly available test, though it is expensive. You need to be careful on that front. So I would do genetics in this patient also. And if my genetic test is negative, patient is normotensive, I will treat it as a sporadic, freestanding, isolated, single pheochromocytoma, and I may be able to discharge this patient from my care. But I am concerned about your patient because of few things. A, it's a metanephrine secreting pheochromocytoma, and I would want to rule out MEN2 as syndrome, very likely to be A, less likely to be B. Second, I'm worried about the left-sided lesion, which is 7 millimeters. So even if patient is normotensive, even if I have not found anything on genetic sampling, even if calcitonin is negative, I will still continue to monitor this patient by annual monitoring of blood pressure and biochemistry. That's what I would do.
Thank you. Fantastic. So
Thank you.
we have really understood well that how to follow, because normally we would have just said blood pressure and just monitor metanephrines, and if we are okay, we are happy, our job is over. But you really made our thoughts so clear that one, the genetic, because he is young. Second thing is thyroid and family. So these are the very important things I think one has to, not only in exam but even in practical, they have to remember. So anything else, Ganesh, you want to add anything? Mahendra?
No, sir. I think Madam already covered everything fantastically about Daniel. Even I got many things clear in this class.
From her every time. You
Yes, yes. Always in every adrenal meet, we always get something new from Madam.
And that is not only in adrenal. I have sent so many cases, and in when I don't know, even in infertility, so many things have, rare things she has found out. So
Yes,
we are
right, sir.
really, really thankful to Nalini, really, and I know, in my view, she is one of the best in our country, and we are really blessed in Mumbai that we have got her with us, so we can send cases to her. Nalini,
Agree,
thank
sir.
you very much.
Thank you.
Thank you, Madam. Thank you.
Thank you.
Thank you, Ojas, and thank you,
very much.
Thank you, ma'am.
Mriganka. Thank you
Yeah.
very much. I'm
Thank you.
sorry,
Thank you,
I
ma'am.
didn't mean to pick on you, but I just was trying to clarify things for you.
Yes.
Okay?
Thank you, ma'am. Thank
All
you.
the
you.
best.
Thank you,
All the
ma'am.
best.
Thank you
Thank
so
you.
much.
Okay. So Ojas and Mriganka, both of you have answered very well. We are happy that you are reading and coming, and please continue the same. I am requesting all the students. Thank you very much.
Thank you. Thank
Thank
you.
you, sir.
Thank you, Ganesh and Mahendra. Thank you very much.
Yeah. Thank you, sir. Thank you. Good night, sir.
Okay, Hiren, bye.
Good night.
Thank you, sir.
Thank you, Nalini. Thank you, bye.
Thank you. Bye-bye.
Good night.
Bye.
Thank you.